Hello guys, I'm Dr. Meenu and today we'll be continuing with our national test and discussion module and this is gynecology. Let's take the first question. A 32-year-old woman presents with acute lower abdominal pain, nausea and vomiting. She reports that the pain started suddenly and is localized to the right side. On physical examination, there is tenderness in the right lower quadrant with guarding. A transvaginal ultrasound is performed and the image is shown below. Based on the clinical presentation and ultrasound findings, which structure is most likely affected? Whenever you get a question like this, or whenever you have got a woman in the reproductive age group who presents with abdominal pain, nausea, vomiting, the first diagnosis that should come to your mind is an ectopic pregnancy. But here, see how they have not mentioned anything with regards to the urine pregnancy test. So it is if it is an ectopic pregnancy, in all likelihood the question will mention that a urine pregnancy test has been done, or they'll give something with regards to beta HCG. Nothing of that sort has been mentioned here. So let us look at the ultrasound picture. What is it that you see here? They have marked the left ovary. Here, this one here is the left ovary, and they've shown the right ovary. See how much enlarged the right ovary is as compared to the left ovary. What we see is that here the right ovary has twisted, or what is known as an ovarian torsion. Which is the structure on which the ovary twists is what we have to know. Fallopian tube. Yes, fallopian tube is one of the structures that can be involved in an ovarian torsion, but it is not the most common one. Uterine artery is not directly involved. Ovarian ligament. What is the ovarian ligament? Ovarian ligament is the structure that connects the ovary to the uterus. It is also not directly involved in ovarian torsion. Now we come to the infundibulopelvic ligament, also known as the suspensory ligament of the ovary. What does it do? It connects the ovary to the pelvic side wall. This is the ligament that is most commonly involved in ovarian torsion. So here your answer is the infundibulopelvic ligament. What does the IP ligament have? The IP ligament contains the ovarian blood vessels. That is the ovarian artery and the vein. So what happens when it twists? We find that there can be an acute pain and it can lead to ovarian necrosis because of the vessels that are present in the infundibulopelvic ligament. Okay, so that is how we have arrived at that answer. Next question. A 28-year-old woman presents to the emergency department with sudden onset of severe lower abdominal pain and dizziness. She reports that her last menstrual period was 6 weeks ago. See, just like in the previous question, she has got lower abdominal pain and dizziness also. But they have mentioned specifically about her LMP. Once that has been given, immediately think of an ectopic pregnancy. On physical examination, she has tenderness and guarding in the lower abdomen. A transvaginal scan is inconclusive, but the clinical suspicion for a ruptured ectopic pregnancy is high. The physician decides to perform a culdocentesis to confirm the diagnosis. Which anatomical space is accessed during a culdocentesis? They have given the picture also. See, now here the needle has been introduced through this is the posterior vaginal fornix. The needle has been inserted through the posterior vaginal fornix into where? Into the recto-uterine pouch. This is the recto-uterine pouch, also known as the pouch of Douglas. So that is where a culdocentesis is performed, in the recto-uterine pouch. Let us look at the other choices. You've got the vesico-uterine pouch. Where is that? This one here is a vesico-uterine pouch between the bladder and the uterus. And the retropubic space, also known as the space of Retzius. That is not the answer here. Here it is a recto-uterine pouch, or the pouch of Douglas. Now, what is the importance of the pouch of Douglas, or why is a culdocentesis performed in the pouch of Douglas? See, this one here, the recto-uterine pouch here, this is the lowest part in the female pelvis, lowest point in the female pelvic cavity. And this is where any blood or fluid may accumulate. So once you have done a culdocentesis, what are the things you can expect to aspirate, or what all diagnosis can you make from a culdocentesis? You can aspirate serous fluid. If it is serous fluid that you have aspirated, it probably means that the woman is post-ovulation. What if you have aspirated clotted blood? If the blood that you have aspirated clots, it means that you have entered a blood vessel. But if you are aspirating a non-clotting blood, it is indicative of a ruptured ectopic pregnancy, because blood from a ruptured ectopic will not clot. So these are the three things that you can aspirate from the pouch of Douglas. These are the three kinds of fluid. So if you get a question, you've aspirated clotted blood, what is it? Immediately think that your needle has entered a blood vessel. Okay. Next question. A 25-year-old woman presents to the gynecology department for her annual exam. She has no complaints and reports regular menstrual cycles. During the pelvic examination, the physician notes that the uterus is anteverted and palpable through the anterior vaginal wall. The examination findings are consistent with the normal anatomy. Which of the following best describes the normal position of the uterus in most women? All of you must have done a vaginal examination. How do you feel the uterus? The uterus is felt through the anterior vaginal wall like this. What is this position? The normal position of the uterus is an anteverted and anteflexed. So there are two angles here. Here this one, that is the angle between the vagina and the cervix, is the angle of anteversion between the cervix and vagina. And this angle, look at this, this is almost a right angle. This angle is about 90 degree. That is the angle of anteversion. Now, next one, here, you have another angle here, an obtuse angle. That is the angle of anteflexion. The angle of anteflexion is formed between the uterus and the cervix, and that is around 120 degrees. See, you've got the body of the uterus here and the cervix here. That angle which is formed there is the angle of anteflexion, while the other one is the angle of anteversion. Normally, the position of the uterus is one of anteversion and anteflexion. Okay, you've got the both those angles also. Now, what maintains this? You know about the supports of the uterus. We'll come to that in detail in the section on uterine prolapse. But there are a couple of things that you need to know. There are a few ligaments that help maintain this position. That is the position of anteversion. Which is the ligament? The ligament which helps keep the uterus anteverted is the round ligament. Remember, round ligament is a secondary support of the uterus. It keeps the uterus anteverted. Now, which is the ligament that prevents retroversion? The ligament which prevents retroversion is the uterosacral ligament. Please remember these two. If the uterus is going in for a prolapse, the first thing that happens is the uterus becomes retroverted. The first step for a prolapse is a retroversion of the uterus. Now, where is it that you see a fixed retroverted uterus? That is seen in endometriosis. That one also you need to know. A fixed retroverted uterus is a typical feature of endometriosis. Okay, and the first step in UV prolapse is also the retroversion of the uterus. I hope that much is clear. Simple things only: anteversion, anteflexion, what the angles are, where it is formed from, which is the ligament that keeps the uterus anteverted, what prevents retroversion. Okay. Now let us go to the physiology. A 29-year-old woman presents to the fertility clinic with a 2-year history of difficulty conceiving. She reports regular menstrual cycles occurring every 28 days with normal flow and duration. Her medical history is unremarkable and she has not been on any contraceptives for over 3 years. A serum progesterone level is measured on day 21 of her menstrual cycle and found to be significantly low. Which of the following is the most likely explanation for her low progesterone level and difficulty conceiving? See, when we say that a woman has got regular menstrual cycles, immediately we think that she is ovulating properly. That is the first thing that should come to your mind. Now here, but they have mentioned the serum progesterone on day 21 to be extremely significantly low. Let us just look at the choices. We'll start with the most common thing that we know, which is the PCOS. Now, PCOS can be eliminated. You have to remember that we are trying to find the answers and not studying the theory here. How we arrive at an answer, that is what is important for us. So when you look at the choices, you find that you can immediately, since they have already mentioned that the woman is having regular menstrual cycles, you can exclude PCOS, because in almost all cases of PCOS, the woman presents with irregular cycles. So that is not the case here. Is it a premature ovarian failure? No. If the woman had a premature ovarian failure, she would have presented with amenorrhea, not regular menstrual cycles. Did you understand how we eliminated those? This one will present with irregular cycles. So that is not the answer. This one will present with amenorrhea. That is also not the answer. Now, we have got two other choices, that is anovulation and luteal phase defect. What is luteal phase defect? Luteal phase defect means there is inadequate progesterone production by the corpus luteum. It may present like this, but one important thing is that in the case of luteal phase defect, the progesterone levels will not be significantly low. So, we arrive at an answer of anovulation. We'll take a short technical break. So I'm sorry, we had a slight technical glitch. So I'll just go through the questions that we have done so far quickly once more. This is from the anatomy. See, you already know the answer. This was an ovarian torsion. Look at the ovaries. This one here, the right ovary is enlarged while the left ovary is of normal size. What happens? The ovary twists on the infundibulopelvic ligament. The infundibulopelvic ligament contains the ovarian vessels, ovarian artery and vein, which can lead to ovarian necrosis. Okay, ovarian necrosis, and the presentation will be one of acute pain. Fallopian tube, yes, it can be involved, but the more common one is the infundibulopelvic ligament, also known as the suspensory ligament of the ovary. All right. The next question was the one about culdocentesis. Where is culdocentesis performed? Look, the one anteriorly, anterior to the uterus, between the uterus and the bladder, this space here, this one, this is the vesicouterine pouch. While the space between the uterus and the rectum, this space here, this is the rectouterine pouch, also known as the pouch of Douglas. This is the most dependent part of the female pelvic cavity, and if at all there is an intra-abdominal bleed, the blood will collect in the rectouterine pouch or the pouch of Douglas, which is where we perform a culdocentesis. What are the things we can aspirate? One is serous fluid, which is seen in a case of post-ovulatory. Then you've got the clotted blood, if at all you have gone into a blood vessel. And if it is a non-clotting blood that you are aspirating from the POD, that means it is a ruptured ectopic. All right. Coming to our third question, what is the normal position of the uterus? The normal position of the uterus is one of anteversion and anteflexion. All right. So, anteflexion, or the angle of anteversion, two angles are being formed. The first angle is between the body of the uterus and the cervix, while the other angle is between the cervix and the vagina. The angle that is formed between the uterine body, that is, this is the uterine body, and the cervix, this angle here, this one, this is called the angle of anteflexion. This is an obtuse angle and is around 120 degrees. While the other angle, this one formed between the cervix and the vagina, nearly a right angle. This is the angle of anteversion. It is around 90 degrees. All right. We'll discuss the supports of the uterus later. Couple of things that you need to know, which is the ligament that keeps the uterus anteverted. It is the round ligament, which is a secondary support of the uterus. While the ligament which prevents the retroversion of the uterus is the uterosacral ligament. A fixed retroverted uterus is seen in endometriosis, and the first step that occurs in a UV prolapse, in a pelvic organ prolapse, is retroversion of the uterus. Now we'll move on to the reproductive physiology. What was her question? You had a 29-year-old woman who had regular menstrual cycles but unable to conceive. She had a serum progesterone level measured on day 21, which was found to be significantly low. Every word is important. See how they have mentioned it as significantly low. Okay. You were easily able to omit PCOS and premature ovarian failure from the question itself, because PCOS would present with irregular cycles and premature ovarian failure would present with amenorrhea. So it is either anovulation or luteal phase defect. You know that in luteal phase defect, there is inadequate production of progesterone by the corpus luteum, but the level is not significantly low. So you see how important that word is there. It is not significantly low. A significantly low level of serum progesterone on day 21 is seen in a case of anovulation. So even though this woman was having regular cycles, her diagnosis is anovulation. I hope this is clear. Now we've got the hormones in the menstrual cycle. One question that you can expect to get is, what is the level of each of the hormones on the day of ovulation? See, none of the hormones are low at the time of ovulation. So if you're asked a question, which is the hormone that is low, none of the hormones are low. All the hormones, that is LH, FSH, estrogen and progesterone, which are the 4 hormones that are directly involved in the menstrual cycle. The levels of all these hormones are high on the day of ovulation. Okay, please remember that. Then what happens? What does the LH do? The LH will go and luteinize the granulosa cells. Okay, that you know, luteinizes the granulosa cells, and the corpus luteum is formed. There is you got a luteinized follicle. What does a luteinized follicle do? The luteinized follicle will secrete progesterone. Now, under LH surge, you know that meiosis 1 is completed. We discussed this yesterday in oogenesis. Once meiosis 1 is completed, the LH surge has occurred, then the corpus luteum starts secreting progesterone. The LH surge increases the secretion of progesterone initially, and the maximum levels are seen on day 21 and day 22. So, very low progesterone means ovulation has not occurred. Okay, that is how we came to this answer. Next question. Now, this is a histological question. A 28-year-old female presents for evaluation of abnormal uterine bleeding. Based on the given image, during which phase of the menstrual cycle was this biopsy most likely obtained? What do you see on the biopsy? You can see what? See here, these are the glands that you see on this biopsy. This one is a biopsy of a proliferative or a follicular phase. They've given the histology there. What are the things that you can expect? You've got, if it is in the early menstrual phase, in the phases of the menstrual cycle, if it is in the menstrual phase, that is from day 1 to day 5, what you know that it is a menstrual phase. So, what do you see if a histology is done? You can see disorganized glands. There can be an increase in the inflammatory cells in areas of fibrin deposition. But this one, what did we have? We had a proliferative or the follicular phase taking place from day 6 to day 14. The histology will show elongated and tightly packed glands. There will be minimal luminal secretions. See, we have got tightly packed glands with minimal luminal secretions. Okay, there is increase in stromal cellularity and fibrosis. Now we come to the ovulatory phase. Again, it is more or less similar to the proliferative phase. Excuse me. Then you have got the luteal phase. Luteal phase is from day 15 to day 28. Here, this one is important. The glands become torches and there are abundant luminal secretions. Where is this seen? In the luteal phase. Alright. So, a couple of things you need to know about the ovulatory phase. What is the sign of ovulation? What is the first sign of ovulation? First sign of ovulation that you can see on endometrial biopsy is a subnuclear vacillation. Typically, you can see this if a biopsy is taken on day 17. So, what are that is about ovulation, and these glands which have become very tortuous and are filled with abundant luminal secretions, these are called the corkscrew glands. Or you can say that they have got a saw-tooth appearance. Okay, so this one is important because if they are asked when is endometrial biopsy done in a case of or in evaluation of infertility, it is done on day 21. Now we come to the premenstrual phase. Again, the histology is similar to that of the early proliferative phase. So what was our answer here? Here the answer is a proliferative or a follicular phase. That is a histology which is shown in this question. Next one, a 32-year-old woman presents to the fertility clinic with a 1-year history of difficulty conceiving. She has regular menstrual cycles every 28 days. Her partner's semen analysis is normal. A hysterosalpingogram shows patent fallopian tubes. On day 14 of her cycle, she undergoes a transvaginal ultrasound which shows a dominant follicle in the right ovary. She is advised to time intercourse around ovulation. Which of the following is the most accurate indicator that fertilization is likely to occur? Now they have asked for the hormone that is indicative of ovulation, because that is when you ask the patient to time her intercourse. Which is the hormone that is involved in ovulation? It is the LH surge, that is a peak in the serum luteinizing hormone levels. Now, let us look at the choices. Detection of ovum in the fallopian tube. Is that done? Have you heard it being done anywhere? No, it is not routinely done in clinical practice. Then you've got presence of sperm in the cervix. Sperm in the cervix does not guarantee fertility. Basal body temperature rise. It just reflects the effect of progesterone. That also does not indicate ovulation. We have mentioned peak serum LH level. When does ovulation occur? Ovulation occurs around 24 to 36 hours after the beginning of the LH surge, and 10 to 12 hours after the peak of the LH surge. Okay, so which is a hormone that you look for to detect ovulation? It is LH. So if you get a question like this, the most accurate indicator that fertilization is likely to occur, you should look for the luteinizing hormone levels. Next question. A 28-year-old woman is undergoing evaluation for infertility. She has regular 28-day menstrual cycles and ovulates regularly. She has been using ovulation predictor kits. What does ovulation predictor kit measure? Which measures the luteinizing hormone at home and notices a positive result typically around day 14 of her cycle. She asks about the timing of intercourse to maximize her chance of conception. What best describes the relationship? This we just said. When does ovulation occur? 24 to 36 hours after the onset of the LH surge and 10 to 12 hours after the peak of the LH surge. So it is 24 to 36 hours after LH surge. Question 8. A 34-year-old woman is being treated for infertility and is undergoing ovulation induction therapy. She has been prescribed clomiphene citrate, which she takes on day 3 to day 7 of her menstrual cycle. After completing the course, she is monitored with transvaginal ultrasound to assess follicular development. On day 12 of her cycle, a dominant follicle is seen and she is advised to administer an injection of HCG to trigger ovulation. What is the primary mechanism of action of clomiphene citrate in inducing ovulation? What is clomiphene citrate? That is the first thing you should know. Clomiphene citrate is an ovulation inducing agent. It is a selective estrogen receptor modulator. You know about this one where hypothalamus secretes a pulsatile secretion of GnRH from the hypothalamus. It acts on the pituitary secreting FSH, which acts on the ovary, and it secretes estrogen, which has got a negative feedback effect. Now, what clomiphene citrate does is it binds to the estrogen receptors. It is a selective estrogen receptor modulator. It binds to the estrogen receptors in the hypothalamus. Okay, and what does it do? It blocks the negative feedback effect of estrogen. Once the negative feedback effect is lost, then GnRH increases, FSH and LH increases. What happens? There is promotion, or it promotes the development of a follicle, resulting in ovulation. Let us look at the choices. Direct stimulation of the ovaries to produce more follicles? No. Does it inhibit gonadotropin GnRH secretion? No. In fact, what is it that it does? It does not increase, it increases it does not decrease, but it increases the GnRH secretion by blocking the negative feedback effect of estrogen. Then, it blocks the estrogen receptors in the hypothalamus. That is the one that we just discussed. It blocks estrogen receptors. Why? Because it is a selective estrogen receptor modulator. Does it mimic the action of LH to trigger ovulation? No. What triggers ovulation, that is said here? She is advised to administer an injection of HCG. So what is this? This is the action of HCG. If the question had said, what is the primary mechanism of action of HCG in inducing ovulation? The answer would be, it mimics the action of LH to trigger ovulation. You've got the difference, right? Let's move on to question 9. A 28-year-old woman undergoing fertility evaluation has a biopsy taken from her ovarian tissue. The histological section of the biopsy is shown below. When did we say that fertility evaluation biopsy is done? On around day 21. Now the biopsy is given here. What does the image show? It shows a large round cell with a prominent nucleus surrounded by a thick eosinophilic layer known as a zona pellucida. Several smaller surrounding cells are seen forming a corona radiata around the central cell. Which of the following cells plays a critical role in the hormonal regulation of follicular development during the menstrual cycle? Okay, they have mentioned a lot of distractors. They have talked, I don't even know why they have given the picture there. They have just said, only thing you need to know is what is the cell that plays a role in hormonal regulation of follicular development. What is this that they have given here? This is a primary follicle. It is formed from a primordial follicle under the influence of FSH. Now let us look at the cells. These are the follicular cells. Follicular cells have been differentiated into what? Into the granulosa cells and the theca cells. Now let us look at the choices. What do the theca cells secrete? The theca cells secretes androgen. So is androgen important in menstrual cycle? No. So that is gone. The granulosa cells, what do they secrete? They secrete estrogen. And what about the luteal cells? Luteal cells, how do they help in menstrual cycle? They are actually derived from, they secrete progesterone, that you know, and they are derived from both the theca cells and the granulosa cells after ovulation has occurred. And the Sertoli cells have got nothing to do here. Sertoli cells are seen in males and they secrete testosterone. So, which is the hormone that is important in the menstrual cycle that has been mentioned here? It is estrogen. So, what is the answer? Which is the cell that plays an important role in hormone regulation in a menstrual cycle? It is the granulosa cells. Question 10. With that we start menopause. A 48-year-old female suffering from severe menorrhagia underwent hysterectomy. She is only 48 years old. She wishes to take hormone replacement therapy. Physical examination and breast are normal, but X-ray shows osteoporosis. What is the treatment of choice? Now, you need to know the treatment of choice for osteoporosis in a woman who has undergone hysterectomy. But then, look at her age. She is 40. She is 48 years old. So, they have not mentioned she has had severe DUB and she underwent hysterectomy. What will you do as the treatment of osteoporosis in this woman? The answers they have given are progesterone, estrogen and progesterone, estrogen none. Now, what is menopause? A couple of things about menopause. If the woman has not had menses for 6 months or more, remember the definition, it is 6 months or more if she has been having regular cycles previously, or 12 months or more if she has been having irregular cycles previously in the absence of pregnancy is menopause. Okay, that is secondary amenorrhea. Now, if there is another entity called a premature ovarian insufficiency. That is using, we come to the definition of premature ovarian insufficiency using FSH. But as far as menopause is concerned, it is a clinical diagnosis. Or remember that, how do you diagnose menopause? It is diagnosed clinically, not by FSH. There is no need for any FSH levels. But anyway, if you are asked, what is a hormone profile in menopause? Hormone profile in menopause. The levels of estrogen, inhibin B and AMH will fall while FSH and LH will rise. This is the hormone profile in menopause. Okay, that was just a couple of things about menopause. Now they've got the reproductive staging. This is the Stroh system, Stroh staging system. It is used for the reproductive aging in women. And there is a period called the perimenopause where you have got a variable cycle length which lasts around 4 to 5 years. But none of that was our question. Our question was how to treat osteoporosis in this particular woman. The answer is estrogen. We'll discuss that in detail when we come to the hormone replacement therapy in the next questions. Next one, a 70-year-old postmenopausal female presents to the gynecology clinic with persistent heavy abnormal uterine bleeding for the past month. On pelvic examination, her uterus is normal in size and shape. A transvaginal ultrasound is performed, revealing an endometrial thickness of 3 millimeters. Only 3 millimeters is her endometrial thickness. There is no evidence of uterine masses or polyps. Considering her clinical presentation, what is the most appropriate next step in the management? So, in such a woman, when her endometrial thickness is very low, that is less than 4 millimeter, we think that What is the risk that you're looking for? A woman has presented with postmenopausal bleeding. It may be suggestive of a carcinoma of the endometrium, which is why whenever we get a woman like that with postmenopausal bleeding, we'll be doing a transvaginal scan to look for the endometrial thickness. If the endometrial thickness is 4 millimeters or less, we say that she is at a low risk for endometrial carcinoma. If it is more than 4 millimeters, she is at an increased risk for endometrial carcinoma, and you say an endometrial sampling or a biopsy is recommended. So, whenever you have a woman with less than 4 millimeters, the most probable cause for the bleeding is, the most common cause for a postmenstrual bleed is due to deficiency of estrogen or senile endometritis or atrophic endometritis. In that case, what you should do is to treat the woman symptomatically. For any case of a woman presenting with bleeding, what is it that you do? You will give her tranexamic acid. So, you begin tranexamic acid therapy. You have understood why we are not performing an endometrial biopsy immediately. You cannot reassure the patient and send her home because she is symptomatic. You need to do something. You don't need to give oral contraceptive pills because she is already 70 years old and she is menopausal. So, that has got no role here. So, you'll begin tranexamic acid therapy. Now, even after taking tranexamic acid, what if she continues to bleed? What will you do then? You've given her symptomatic management, tranexamic acid. So, tranexamic acid, bleeding continues. Bleeding continues with tranexamic acid. At that point, you have to do a fractional curettage, not an endometrial biopsy because her endometrial thickness is less than 4 millimeter. If it continues with tranexa, what is the next thing that you do? It is a fractional curettage. All right. Is that clear? Let's go to the next question. This is the question where we'll discuss the hormone replacement therapies. Which of the following statements regarding HRT in menopause is incorrect? Estrogen-only HRT increases the risk of endometrial hyperplasia in women with an intact uterus. Is that correct? Yes, that is correct. Next one. Combined HRT is effective in reducing bone mineral density loss in postmenopausal women. HRT is universally recommended for the primary prevention of cardiovascular disease in postmenopausal women. HRT usage is associated with an elevated risk of venous thromboembolism. Here the correct answer or the statement which is incorrect is this one. HRT is universally recommended for the primary prevention of cardiovascular disease. Remember that HRT cannot prevent cardiovascular disease. So what is the primary use of HRT? The primary use is in the management of vasomotor symptoms like hot flushes or night sweats and the prevention of osteoporosis. The single most important use of HRT is the management of vasomotor symptoms. It may be considered for atrophic vaginitis or senile vaginitis also. But if your question is, what is the first line treatment of atrophic vaginitis? Your answer should be vaginal lubricants, not HRT. Okay. And if it fails, then the second line is topical estrogen. Clear, no? First line treatment is, it is a secondary use for vaginal dryness and atrophic vaginitis. Now, when do you give estrogen only HRT? If the woman has got an intact uterus, you cannot give estrogen only HRT because there is an increased risk of endometrial hyperplasia. If you get a question, a hysterectomy has been done for a woman and you would like to give her an HRT. Would you give her an estrogen only HRT? You can, but then you have to look at the question once more carefully. If the question says that the hysterectomy was done for endometriosis, you just cannot give her estrogen only HRT because there may be endometriotic deposits at other places within the abdominal cavity or elsewhere, which can also undergo endometrial hyperplasia under the influence of estrogen. All right. So, what are the risk factors that are associated with HRT? venous thromboembolism because there is an increased risk in estrogen progesterone therapy, breast cancer, and some cardiovascular events. You know that it provides symptom relief, it helps in bone health. Ideally, it is meant for a short-term use. Then, here you've got some non-hormonal options. What are the non-hormonal options? You have SSRIs, you've gabapentin, and then you've got some lifestyle modifications. Now, one important thing that you need to know here is with regard to osteoporosis. Osteoporosis. Osteoporosis is the single most important health hazard of menopause. If you're asked a question, that is the most important health hazard. How is it diagnosed? It is diagnosed by dual energy X-ray absorptiometry or by the DEXA scan that measures what? It measures the bone mineral density, and it is best measured at the hip. How is it prevented? It can be prevented using calcium, vitamin D or calcitonin. What is the treatment? The first line treatment of osteoporosis is bisphosphonates. You must have studied this in your ortho classes. Bisphosphonates like alendronate or risendronate. If you're asked the next one, we had our first question, how do you treat osteoporosis in a hysterectomized woman? If bisphosphonates is not given in the choices, your next answer is estrogen. Okay. That is about osteoporosis. Now from there we'll move on to one other thing that I wanted to mention here. They've mentioned a selective estrogen receptor modulators such as raloxifene. There is another one that we need to mention, that is the STEER, selective tissue estrogen activity regulator, which is that it is Tibolon. That is also used in menopausal hormone therapy. We come to puberty. There is a 13-year-old girl. Before we start that, we'll take a short break. So let's start puberty. Before we start puberty, how does puberty occur? What happens? In the hypothalamus starts releasing GnRH in a pulsatile manner, and this acts on the GnRH is released, not continuous, remember that, in a pulsatile manner. This acts on the pituitary. What does the pituitary do? It secretes LH and FSH, which act on the ovary. And then what happens? From the ovary, estrogen is released, which stimulates a growth hormone and further puberty. And there is also follicular development. Clear? So that is how puberty occurs. In puberty, there is thelarchy or breast budding, which is the first visible sign of puberty. It is followed by pubarchy. Then there is an increase in height, and then finally menstruation. Normally, puberty occurs at around 8 to 12 years. Here, this girl is 13 years. She is brought to the clinic by her mother because of concerns about her delayed physical development. The mother reports that most of the girl's classmates have started their periods, but her daughter has not. The girl has noticed some breast development and a few pubic hairs, but no other signs of puberty. On examination, her height and weight are within the normal range for her age, and her Tanner staging shows breast development at Tanner stage 2 and pubic hair at Tanner stage 2. Laboratory tests reveal normal LH and FSH levels. Which of the following is the most likely diagnosis? You cannot remember all the Tanner stages. So if you get that she is around 1 or 2, then that means it is a childhood, her breast and her pubic hair and the childhood range. And in 4 and 5, it is in the adult range. Alright, that much you can remember, right? So here, Tanner stage 2 and both her breast development and pubic hair are at 2 only. Everything else is normal, okay? So, let us look at the choices. Hypogonadotropic hypogonadism. What does that mean? The LH and FSH levels will be low. Why? Because there will be deficiency in the GnRH. So, here her LH and FSH are normal. In hypogonadotropic hypogonadism, LH and FSH is low. What about Turner syndrome? Can this be a case of Turner syndrome? What is Turner syndrome? It is a case of an ovarian dysgenesis. So here the secondary sexual characters will be underdeveloped, and there will be characteristic physical features of Turner syndrome, but none of that have been described here. So it is not Turner syndrome. What is precocious puberty? Precocious puberty means puberty or menstruation that occurs in a girl who is less than 8 years old. That is also not the case here. This here is the most common cause of delayed puberty. What is it? It is a constitutional delay. This is the most common cause. She has got, in the question they have mentioned that she has got a normal growth pattern. It is Tanner stage 2, normal LH, normal FSH. So, and everything else, the pubertal development is as in the expected range, but delayed compared to her peers. That is why her mother is worried and has brought her. What do you tell the woman? What do you tell the mother? You will tell her that the condition will resolve on its own and puberty will eventually ensue. Next question. A 7-year-old girl is brought to the clinic by her parents because they have noticed that she has started developing breasts and pubic hair. Her parents are concerned because she is the first in her class to show the signs of puberty. On examination, the girl is found to have Tanner stage 3 breast development and Tanner stage 2 pubic hair. Height and weight are above the 95th centile for her age. Bone study shows advanced bone maturation corresponding to that of a 9-year-old. Laboratory tests reveal elevated levels of LH and FSH after a GnRH stimulation. Which of the following is the most likely diagnosis? What is this? This is a case of a central precocious puberty. What is a central precocious puberty? That is puberty occurring in a child who is less than 8 years of age, is of 2 types. It can be central or it can be peripheral. If you take a central precocious puberty or a gonadotropin dependent precocious puberty, you find that both LH and FSH are high. In most of the cases, or the most common reason is idiopathic. It is constitution. There is nothing that is to be done about it. Okay. LH, FSH are high. She starts menstruating early. But then there are certain CNS abnormalities like hydrocephalus or some infections or some surgeries that you will have to rule out. It can also occur as a result of hypothyroidism. Now we have got a peripheral precocious puberty. Peripheral precocious puberty is never constitutional. It is a gonadotropin independent, that is LH and FSH are low. It may be due to some tumors or ovarian or adrenal or testicular tumors there is an exogenous secretion of the sex hormones, which is why peripheral precocious puberty occurs. Peripheral precocious puberty, if you are looking into it, it can be divided into two. It can either be isosexual or heterosexual. Isosexual means there is an excessive secretion of estrogens, which is usually seen in granulosa cell tumors of the ovary. Or it can be seen in feminizing tumors, adrenal feminizing tumors of the adrenal glands, or there may be ectopic gonadotropin production like in dysgerminoma, in choriocarcinoma, or in hepatoblastoma, or there is exogenous estrogens that are being taken like oral contraceptive pills or some corticosteroids. It is also seen in the case of McCune-Albright syndrome. That one you need to know. McCune-Albright, it has been asked several times, that is McCune-Albright is a syndrome that presents with the precocious puberty. There is precocious puberty. There are typical skin lesions called the cafe au lait spots and polyostotic fibrous dysplasia. This is the triad of McCune-Albright syndrome, which is caused due to a somatic mutation of the alpha subunit of G protein. Okay, this is with regard to the isosexual puberty. What about the heterosexual puberty? The most important thing with regards to heterosexual puberty is a congenital adrenal hyperplasia. It can also be seen in ovarian or adrenal testosterone secreting tumors, or there is exogenous intake of androgens. Okay, that is about precocious puberty. Now we have a 2-year-old female. She is brought to the pediatric endocrinology clinic with concerns of ambiguous genitalia noted at birth and persistent hypertension despite standard treatment. Lab investigations reveal elevated 17-hydroxyprogesterone levels. Genetic testing confirms a 46XX karyotype. Considering her clinical presentation and biochemical findings, which of the following enzyme deficiencies is most likely responsible for her condition? I'm sure you know the diagnosis. This is a case of congenital adrenal hyperplasia or CAH. Immediately don't jump into the answer, okay? Because they have asked, consider her clinical presentation. Which is the most common enzyme that is involved in CAH? It is 21-hydroxylase. But is that the answer here? In 21-hydroxylase, the presentation is slightly different. There can be virilization. There can be salt wasting. That is, the child may present with hyponatremia and hyperkalemia. While in 11-beta-hydroxylase, which is the second most common cause for congenital hyperplasia, adrenal hyperplasia, the child will present with hypertension. Why? Because of deoxycorticosterone accumulation. Here they have mentioned it. She has got persistent hypertension. So in that case, the answer is 11-beta-hydroxylase. Look at the choices. 21-hydroxylase, it is the most common, but there is possible salt wasting. While 11-beta-hydroxylase, which is the second most common, you can see hypertension due to deoxycorticosterone accumulation. Then we have got 17-alpha-hydroxylase. It will present with hypertension and sexual infantilism. All right. So look at the choices carefully before you come to your answer. Now let us just take a look at the biochemical markers. 17-OHP, which is the one that has been elevated here. It is elevated in both 21-hydroxylase and 11-beta-hydroxylase deficiencies. While DOC levels are elevated only in 11-beta-hydroxylase. That has not been mentioned here. They have only mentioned 17-hydroxyprogesterone. But since they have specifically said that the child has got persistent hypertension, your answer should be 11-beta-hydroxylase. I hope you understood how we reached that answer, right? Now, they have given the clinical presentation correlation, how hypertension in CAH narrows the differential towards 11-beta-hydroxylase or 17-alpha-hydroxylase deficiencies. Ambiguous genitalia, that can be there in 21 hydroxylase and 11 beta hydroxylase both. So this clinical presentation correlation here, this is very, very important. Okay. Now, question number 16. A 13-year-old girl is brought to the clinic by her parents due to concerns about early pubertal development. She started developing breast buds at the age of 7 and has had regular menstrual periods since the age of 9. On examination, she is at Tanner stage 5 for breast and pubic hair development. Her born age is significantly advanced compared to her chronological age. She is taller than her peers, but her growth has recently slowed down. A diagnosis of central precocious puberty is made, and the decision is made to start treatment to delay further pubertal progression. What can you use? Why do you want to prevent further pubertal progression? You know that there can be early epiphyseal closure and she will not reach her normal height or such growth potential. What is used? What is letrozole? Letrozole is, this is an aromatase inhibitor. Aromatase inhibitor. What does it do? It decreases estrogen. Medroxyprogesterone acetate, it is a progesterone. What is spironolactone? You have heard this, right? Spironolactone is an androgen receptor antagonist. We come to your answer. Your answer is leuprolide. What is leuprolide? Leuprolide is used for the treatment of central precocious puberty. Continuous leuprolide. Leuprolide is a GnRH analog. When we had discussed puberty, we said that it is a pulsatile secretion of GnRH that causes puberty. But in this case, you are giving GnRH analogs continuously. That is, leuprolide is given. What does it do then? It down-regulates the GnRH receptors. Where? In the pituitary. So what does this do? It decreases the secretion of LH and FSH, and therefore it will decrease estrogen and testosterone or whatever it is that is being produced. Okay, that is clear? Next question. At approximately 10 weeks of gestation, which of the following events is most accurately associated with the Mullerian ducts? Differentiation of the Mullerian ducts into fallopian tubes and non-fused portion. They are given 4 different choices. Now let us just look at the embryological development of the Mullerian ducts. We know that the female internal genitalia are formed from the Mullerian ducts, right? So there are, we'll just go through the key stages. First of all, starting with formation. Mullerian ducts are formed at around the 6 weeks. The formation starts at 6 weeks and they develop parallel to the Wolffian ducts. Then we have got differentiation that happens at 7 to 8 weeks. What is there in differentiation? It differentiates into specific female reproductive organs which starts at 7 to 8 weeks. And then we've got fusion and canalization that happens at 9 to 10 weeks. Where does the fusion start? The fusion begins in the midline and it proceeds cranially and caudally. So the proximal parts fuse at the midline and forms the uterovaginal canal, and then canalization occurs. Canalization where the fused ducts develop a continuous lumen. This is establishing the definitive uterine cavity. And finally, you have got the 4th step where the final differentiation, that is from 11 weeks onwards. Okay. What was the question? What happens at 10 weeks? At 10 weeks, there is fusion of the Mullerian ducts to form the uterovaginal canal and then subsequent canalization. See, fusion starts occurring at 10 weeks. And then, this one also you need to know, there is resorption of the septum at 20 weeks. Let us take a short break.